Today in the show, the science of SSRI withdrawal and why it continues to be a subject of hot debate among physicians and patients.
So what I would say is that the available data is not methodologically strong enough that there's a consensus in the field.
Roughly 1 in 10 Americans take antidepressants. The most common types are SSRIs, or selective serotonin reuptake inhibitors. Think Prozac, Lexapro, Zoloft. But what happens when you stop taking them? There's an ongoing debate among physicians and patients about the severity and prevalence of SSRI withdrawal. Western Reserve University, based in Cleveland, Ohio, and Dr. Mark Horowitz, clinical research fellow in the UK's National Health Service and scientific co-founder of Outro Health. He's based in London, England. I want to welcome you both to Science Friday.
Thanks for having us.
Yeah, thank you.
It seems like there's a lot of disagreement about this issue, about SSRI withdrawal. I mean, is it lighting up the psychiatry community? Are researchers arguing about this in hotel ballrooms somewhere? Avais?
Yeah, I mean, I would say there's a pretty heated debate going on, and I think a fundamental problem is that we have a relative lack of good research and good data, especially about long-term outcomes. I think some of the most interesting and intense debates are happening online at the moment.
Mark, this is personal for you. I mean, this is professional for you, but it's also personal for you. You took antidepressants for a decade. What was your experience coming off of them?
I learned at medical school and in my psychiatry training the same things that Awais has been taught and other psychiatrists, that coming off antidepressants is generally fairly easy. There's brief and mild symptoms and doesn't cause, and that is true if you've been on the drugs for 8 to 12 weeks, because a lot of the research was done by drug companies, looked at people who've been on the drugs for a few weeks. But when I came off my antidepressants, which I tried to do the first time about 10 years ago, I was hit by a raft of symptoms that I hadn't expected. I had trouble sleeping. I would wake up in complete terror, like I was being chased by a wild animal, and that would last for hours and hours of the day. And that went on and on for week after week. In fact, it went on for months until I was forced to go back on the medication. And I should say that these symptoms were nothing like the symptoms that I had gone on antidepressants for many years beforehand as a slightly dissatisfied medical student. And that was a real wake-up call to me that what I had learned in textbooks from short-term studies was not reflected, at least for me, in coming off after long-term use. And I soon realized that it wasn't an isolated experience for me, but something that happened to tens, if not hundreds of thousands of other people.
When I listen to this story, the thing that comes to mind is, you work in this field. If this is such a common experience, why did you not know about it? What breakdown?
Clinical practice working as a psychiatrist in Australia and the UK, we very seldom stopped medications that wasn't replaced by another medication, and we very seldom followed people up. Psychiatry is very much focused on crisis. When people are in trouble, they want to do things to patch people up, and it falls down the list of priorities taking people off medication. So it is not a very big part of practice. In my training, I also didn't receive any lectures on stopping medications, I should say. And that is because there is such a big focus on starting things and not such a big focus on stopping things. That's reflected in research literature, in guidelines, clinical practice, and people's experience. And I did actually have a sort of series of flashbacks where I realized that many patients that I had seen were suffering from withdrawal effects, and I had misdiagnosed them with a relapse of their condition or something else, some other mental health problem, because I had not been aware at the time of what was going on. So I completely understand my colleagues who don't see these things, because it is very hard to see what you haven't been trained to see, and I have stood in their shoes, so I understand completely.
I mean, how can you tell if a patient is having withdrawal symptoms versus relapse?
A few things are, one, there are distinctive symptoms in withdrawal that don't occur in relapse. So there's a whole host of physical symptoms: headaches, dizziness, brain zaps is a particularly distinctive one.
What's a brain zap?
So a brain zap is a sort of sensation of a little electric shock in your head, or that someone has sort of switched your brain off for a second. The other issue, though, is that the most common withdrawal symptoms from antidepressants are psychological symptoms, things like anxiety, low mood, panic attacks, even feeling suicidal. And we know that these are withdrawal symptoms because they occur in people who stop antidepressants who are not put on them for mental health difficulties. So in people who are put on them for pain or the menopause, or even in health volunteers. And patients will often say that. They'll say, when I came off medication, I had symptoms that I'd never had before, or they were much more severe. The other issue is when the symptoms come on. Withdrawal symptoms often come on within a few hours or days of a missed dose, although they can also be delayed by weeks, which really confuses patients and doctors. We think that's because there are downstream effects that take time to reach a threshold that can confuse people. Response to medication is more useful in retrospect. Sometimes when medication is restarted, soon after people stop their medications, withdrawal symptoms quickly resolve, although for some people it can take longer.
Do you see this problem as overlooked in the same way that Mark does?
Yes, I agree. The problem has been overlooked. And from the very beginning, there was no systematic research around what happens when antidepressant medications are stopped, what kind of experiences people have. And to the extent that there was some awareness that withdrawal symptoms happen, they were conceptualized under the category of discontinuation syndrome or discontinuation symptoms, which was essentially a kind of branding that was partly driven by pharmaceutical interest. And so it created this idea that whatever is happening with stopping antidepressants, it's a different kind of thing than withdrawal, and it is milder. And it never received systematic study. And because it never received that kind of research funding and support, clinicians on the ground had very little idea of it. Because we didn't have scientific data, textbooks generally neglected it. And also the kind of clinical culture that we have, in many Western countries, there are incentives and pressures to keep the person on the medication, and there's relatively less support for them to come off it. So all of that, I think, acted in coordination. It is also the case that the question of whether a person is experiencing a return of the depression or development of a new, let's say, anxiety, condition versus withdrawal, the lines are also kind of blurred. There are clear situations where we can say this looks like a return of depression or, a return of anxiety, but there's a pretty gray area in between where a person's prior mental illness and their vulnerability towards mental illness interacts with the fact that they have also developed a dependence on medication. And how to navigate that gray area is also tricky.
What percentage of people who are on antidepressants long-term have these severe withdrawal symptoms? Do we know?
Yeah. So what I would say is that the available data is not methodologically strong enough that there's a consensus in the field. The studies that are available, they suggest a higher percentage, something around 40 to 50%, sometimes even more. But because of various considerations around how these studies were conducted, many people in the field remain kind of unpersuaded or unconvinced.
I have a different view to Awais. I think that's not true what he's just outlined. There are very high quality studies on long-term use that I think psychiatrists like to ignore. There are studies that are done that are double-blinded, so people don't know if they're being taken off the drugs. They're rated with objective instruments. It's after being on the drugs for a year, and they find that 2/3 of people who come off antidepressants after more than a year have withdrawal effects, and that they show that these symptoms have profound impairments in terms of their functioning day to day. So I think we do have good evidence that it is around, could be 50%, but most of these studies show about 2/3 of people have withdrawal effects. I do agree with Awais, though, that a big part of this is how long people have been on the drugs for. And short-term users do have minor problems, longer-term users have more major problems. And of course, in America, there are more than 25 million people who are on these drugs for more than 5 years, and they are in the category of people that are having more severe, more long-lasting, and more disabling symptoms.
One thing I want to mention is that a big element of the controversy is that there's a mismatch between what many clinicians see in their practice and what some of the research studies around long-term use suggest. And and I myself, I've been kind of looking and reading the antidepressant withdrawal literature for many years now. I work in a general psychiatric setting, so I work with all kinds of patients with depression, anxiety, mood disorders who have been on antidepressants for many years. And while I do see a small percentage of people struggling intensely with withdrawal issues, I would say the kind of like the average person seems to kind of handle the withdrawal symptoms quite well with a gentle taper that lasts a couple of weeks.
One of the implications in all this is that patients are not reliable commentators of their own experience. Part of this is, look, psychiatric patients, they take antidepressants, they're a funny bunch of people. Can we really take them seriously? There's a very big, epistemic injustice underlying all this. But we know that, 1 in 2 people in America have been offered an antidepressant at some point in their life. So this is not, a very small, disturbed group of people. This is almost everybody out there.
I would say another big thing is that I think what is the exact percentage of people who have withdrawal is an important question, but also practically not the most important one. I think practically the most important thing is that people who are experiencing significant difficulties with withdrawal, what needs to be done for them? How can we best handle these individuals? And also, how can we prevent severe withdrawal from happening? So I think that's where the focus of clinical research and scientific effort should be, is what is the safest way of tapering antidepressants and what is the safest way of getting people off them.
After the break, how do you get off SSRI antidepressant? Antidepressants. We'll talk about a promising approach to mitigating severe withdrawal symptoms.
Patients are often told, you're on a very small dose of a drug, you can just stop it. But the brain doesn't care about the size of tablet you're swallowing. It cares about the effect of that drug on the brain, on its receptors.
So, you both agree that suffering from severe withdrawal. So, what is the solution for those people who are having this hellish experience?
Yet looking at how best to take people off their drugs. It seems from many observational studies that the slower you come off an antidepressant, the less likely it is to cause withdrawal effects in the short or long term. And people use an analogy to something like altitude sickness. The quicker you go up a mountain, the more likely you are to get into trouble because your body can't adapt to the change in air pressure. If you go up the mountain more slowly, you're less likely to get altitude sickness. And the same seems to be true for coming off psychiatric drugs. Our brains and bodies get used to these drugs. If we reduce it in small amounts over time, it gives the brain and body time to readapt to the drug not being there. And that tends to reduce the risk of withdrawal effects. And that for many patients means coming off over months and sometimes more than a year. And because of the particular pharmacology of the drugs, the last few milligrams are much harder to come off than the first few milligrams. And so it makes sense to go slower and slower as you get down to lower doses.
Oh, and you developed this model, right? This slow tapering model.
Yes. So we published a paper on it. It's called hyperbolic tapering. And I should say that many tens of thousands of patients had worked out the same thing themselves through trial and error over many decades, often without medical help. How do we reduce our medication in a way that we can tolerate? And it was quite a eureka moment for me when I realized that this pattern of reducing that patients had worked out exactly matches the neuroimaging of these drugs and their effect on the brain. And so I think it is a technique that tends to work, and I use it in my clinic, and there's now research projects going on to try to define it better.
And that means, I assume, using liquid, right? Because you can't, you can't split a pill down to the crumbs, right?
Exactly, that's the crux of the matter, which is that the existing tablets or capsules available at pharmacies for all antidepressants have a very large effect on the brain. So patients are often told, you're on a very small dose of a drug, you can just stop it. But the brain doesn't care about the size of tablet you're swallowing. It cares about the effect of that drug on the brain, on its receptors. And so to sort of get down that hill, you need to use, exactly like you've just mentioned, liquids or specially compounded tablets or capsules. And that way people can get off that last sort of steep hill to get down off their drugs.
I think the method of tapering that the Mark is describing, the gradual hyperbolic tapering, I think it's been a wonderful development. And at the same time, we have to recognize that we don't have good high quality evidence from clinical trials, especially say which method is the best one for an average person. People who are having difficulty coming off them, hyperbolic tapering is at the moment the best one.
I am noticing personally, as someone who covers science week in, week out, and has done that for decades, a kind of dangerous flattening of science from all directions. And I wanted your perspective on that. Is there a way for us to better acknowledge uncertainty in science? How do we make uncertainty great again?
That's a good line. I think there is a very worrying flattening of science. Science it's a way of generating new knowledge, and it's also a kind of institution of power. And I think that dissenting have been quietened again and again in medicine. One thing I wanted to point out is that this is actually a repeat story. The same thing happened with benzodiazepines. Doctors said they don't have major withdrawal effects. It's not everybody. We don't think it's physiological. It might be about the patients. It might be relapse. What happens is there's a certain line. It benefits professionals. It comes from industry, and patient voices are quieted. It takes independent researchers without great funding, decades to build up the evidence base to prove that something was not what it was represented to be. And so I really think we have to learn from past experience and be open to new ideas, because otherwise, we've learned great harm is done to patients. So I do think we need to be more open-minded and not so quick to censor dissenting voices, which is happening so much now in psychiatry.
Yeah, my view is that I think we have to openly acknowledge that this is an area in which there's a lot of disagreement in the field, and there are a lot of unknowns. And the reason there is disagreement is that we lack the kind of high quality research that can persuade people. And the answer, I think, is that major funding organizations, they have to make this topic a priority. They have to make research around medication harms and stopping medications a priority. And if they fund research that investigates this issue, we will have the data that resolves these unsettled questions.
I want to thank you both for taking the time to talk with me today on the show.
Thanks, Flo.
Yeah, thank you for covering this.
Dr. Avais Aftab, Clinical Associate Professor of Psychiatry at Case Western Reserve University in Cleveland, Ohio, and Dr. Mark Horowitz, Clinical Research Fellow in the UK's National Health.
With Instacart, you get groceries that over-deliver. Like when you get groceries that are the same price as in-store, with no markups at select retailers. You get in-store products for in-store prices, and the only thing that isn't in-store is you. That means you could order in-store products at in-store prices while you're in sweatpants, in spin class, in stuffy work meeting, in anywhere but in-store. So download the app today and get $0 delivery fees on your first 3 orders. Instacart, groceries that over-deliver. Service fees, exclusions, and terms apply.
Fundamental to all kinds of maps is my guest, Dr. Paulina Rovinska, mathematician, writer, science journalist, and author of the book Mapmatics, How We Navigate the World Through Numbers. She's based in New York City. Paulina, welcome to Science Friday.
Hello, thank you for the invitation.
You're welcome. Can I begin with my pet peeve about how you get into trouble turning a 3-dimensional thing like the Earth into a 2-dimensional map? And this Mercator projection, tell me how all this happened.
Yeah, so I think about making maps a bit like peeling an orange, An orange is round, and when you peel it, you might want to, if you're a mathematician, squash it on a flat table. But you cannot do it without tearing the orange, and that's because of its curvature. And that the same happens with making maps. So, we are turning a curved sphere, the Earth is pretty much a sphere, onto a flat sheet of paper. And eventually he proved that this is actually of different curvatures. You cannot translate it like that without any distortions. Well, we still do it, right? We still create maps. So what does it mean? This means exactly that every single map we create is distorted in some way. It's not a perfect representation of the Earth. So one of the probably most famous world maps out there is Mercator projection. It's a very old projection. It's a type of a map that protects the shapes, so the angles and the shapes of continents and countries, etc., but distorts their sizes. So as we heard a couple of minutes ago, when we look at this map, Greenland looks massive, Africa looks tiny. So, and this is just a mathematical property of this map, and it's just one of the many projections we can make.
So this was basically created for sailors needing to get around the world?
That's correct, yes. Mercator created this map for a particular purpose. So the purpose of this map was to go on the sea and not get lost. And here's where the angles come in. So back in the day, sailors were navigating with a compass and other equipment that required angles. And when you're in the middle of the sea, your main concern is to figure out which direction to go to. Right. Yes, it would be nice to know how long it's going to take, but that's a secondary problem because if you go in the wrong direction, you won't get there at all, right? So that's why Mercator's map was so useful. And we still use it for navigation, kind of versions of Mercator map. Not exactly the same map, centuries old map, but versions of it are on, Google Maps and other online maps. So this map was made for navigation.
Yeah, so it gets the job done in that sense.
It does, yes.
Mm-hmm. Now, I understand you are a mathematician. How did you get into maps? Was this a hobby or something?
Yeah, so I was a bit of a geography nerd at school. I really loved maps and geography. I did even Geography Olympiad or whatever we call it.
Very nerdy, yes.
Yes, very much. I definitely, even as a kid, loved my little globe and the maps we had at home. And I was just planning where I want to go and what I want to see and how these maps work. And then I went on to study mathematics and kind of forgot about this hobby for a bit. And then when I started getting really into science communication and thinking about how to talk about mathematics and what's really cool about mathematics, I kind of remembered about maps, and I started thinking about all these other mathematical properties of maps that we just don't really consider every day. I personally don't consider and forget about them sometimes.